Welcome to our virtual workshop on endpoints for diabetic retinal disease based on the neurovascular unit. This workshop is serving as the kickoff event of the endpoints consensus building process of the Diabetic Retinal Disease Cure Accelerator, which is a collaborative effort of the Mary Tyler Moore Vision Initiative and the CCOI. I'm Dr. S. Robert Levine, the founder and CEO of the Mary Tyler Moore Vision Initiative, or MTM Vision. First, some background on what brings us to this moment. My wife, Mary Tyler Moore, was an optimist. She thought anything was possible, and this hopeful attitude, even in the face of great personal challenges, including her vision loss from diabetic retinal disease, inspired the founding of MTM Vision. And it is the scope and urgency of the problem of diabetic retinal disease, or DRD, that motivates us to action. Many of you know recent data from the Surgeon Today studies demonstrated alarming rates of DRD in youth and young adults, with greater than 50% showing evidence of disease after a mean diabetes duration of only 12 years and at a mean age of 26.4. And of course, each of the over 530 million people and growing with diabetes in the world is at risk for DRD. Finally, DRD is the most common and most feared severe complication of diabetes. Our mission and approach are to accelerate development of medical products to eliminate vision loss in people with diabetes through the breaking down of barriers to progress. The three fundamental obstacles to progress we have identified are: you can't solve a problem you have not defined, you can't cure a human disease without studying the human condition, and you can't judge success unless you know what to measure. Our response has been to help better define DRD via an expert process designed to inform an update of the DRD staging system, to facilitate the study of the human condition by establishing a research-driven ocular biorepository and building a data and specimen sharing platform to engage academia and industry in collaborative research, and the design of clinical studies to validate promising functional endpoints, along with the launch with CCOI of an endpoints consensus building process, of which this virtual workshop is a part. We believe that to better diagnose, predict risk of progression, improve patient selection for clinical trials and care, and assess treatment efficacy requires an updated DRD staging system. We therefore organized a working group process to help identify promising endpoints and biomarkers in people with diabetes relevant to the multiple dimensions of DRD that include retinal vascular disease, retinal neuronal disease, visual function, basic and cellular mechanisms, systemic disease, and quality of life. Each working group published its findings in Ophthalmology Science, and these findings have guided our additional efforts and inform our consensus building process. Our biorepository has been stood up, its SOPs refined, and we are undertaking deep characterization and omic analysis on the first group of human ocular tissue and fluids collected. The data generated and specimens collected are shareable with academic collaborators and industry members of our pre-competitive consortium, with our dedicated secure online data sharing platform launching this summer. An additional outcome of our staging update process has been the design of two clinical studies, one natural history study and the other a post-treatment observational study to assess promising functional endpoints in DRD as measured by commercially available FDA-certified devices. Our top-line goal for these studies is to validate new visual function primary endpoints and surrogate markers that are acceptable for use in clinical trials for regulatory approval of innovative medical products, including those for potential use in early-stage disease. Another outcome of our staging update was confirmation of the need for a new PRO for DRD, which could better assess patient experience, social emotional factors, and visual limitations associated with the degeneration of different retinal cell types. This project is near completion thanks to generous funding from our corporate partner, Boehringer Ingelheim. The item list generated in this project may also have application in assessment of patient-reported outcomes relevant to other neurodegenerative disorders of the retina, such as glaucoma and AMD, which we know is the goal of the broader NEI collaborative effort on PROs led by Emily Chu. To summarize, there is an urgent need to identify, validate, and build consensus on novel endpoints to assess retinal health in people with diabetes, to guide clinical research and medical product development, and enhance patient care. We recognize that DRD affects the entire retinal neurovascular unit, and we need the capacity to objectively assess the relationships between retinal structure and function. We listen to the voices of patients in all we do. Our overarching goal is to facilitate the development of new medical products to prevent and cure vision loss from diabetic retinal disease. And finally, this virtual workshop is the kickoff of the Mary Tyler Moore Vision Initiative, CCOI, DRD Cure Accelerators, consensus building efforts on endpoints and biomarkers for DRD. We will follow up with the publishing of insights gained to be shared with the broader community for feedback, and then hope to generate a white paper for distribution to stakeholders ahead of our fall symposium on curing vision loss from diabetes, which will be held in Ann Arbor, Michigan on November 3rd, and to which you will all be invited. It is now my great pleasure to introduce Dr. Jennifer Sohn, who, in addition to serving as the scientific co-director of the Mary Tyler Moore Vision Initiative, is a professor of ophthalmology at Harvard Medical School, an actively practicing vitreoretinal surgeon at Joslin Diabetes Center, and the chair of diabetes initiatives for the DRCR Retina Network. Dr. Sohn will lead our first session entitled Clinical Assessment of Retinal Structure. Jennie?
Welcome to our first session. I'm the moderator, Dr. Jennifer Sohn, from the Harvard Department of Ophthalmology, Joslin Diabetes Center. And our first talks will focus on endpoints related to clinical assessment of retinal structure. Our first two talks will discuss methods to assess and evidence regarding the role of retinal nonperfusion in diabetic retinal disease. We'll then shift gears in our second two talks to abnormalities in neural retinal structure in DRD. We'll focus first on early neurodegenerative changes and then on later stage disorganization of retinal layers that may directly impact visual function. I'd now like to welcome Dr. Paolo Silva, an associate professor at Harvard Medical School and my colleague at Joslin Diabetes Center. Dr. Silva, along with Lloyd Pauliello at the Joslin, has led many of the studies that have informed our understanding of the role of ultra-wide field retinal imaging in DRD. And he'll be discussing retinal nonperfusion and future risk of vision-threatening complications.
Thank you, Jennie, for that great introduction. So I'll be speaking on retinal nonperfusion and future risk of vision-threatening complications. Retinal nonperfusion is a key pathologic hallmark of diabetic retinopathy. It can be found in eyes without clinically visible or mild disease, but generally increases with disease severity. It's been associated with an increased risk for future DR worsening, as well as DR biomarkers, including retinal leakage, central macular thickening, predominantly peripheral lesions, and increased intraocular VEGF levels. This graph shows nonperfusion extent stratified by DR severity on the x-axis. As DR severity increases, the extent of retinal nonperfusion area is increased. This trend is evident from no DR until severe NPDR, where it levels off. We evaluated the distribution of nonperfusion across the posterior pole, the mid-periphery, and far periphery. This figure shows the total distribution of nonperfusion stratified by DR severity. Comparing eyes with no DR to eyes with PDR, the proportion of nonperfusion in the mid-periphery and posterior retina increased by 1.5 and 6-fold respectively. Our observations have shown that in eyes with NPDR, worse DR severity was consistently associated with increasing nonperfusion on ultra-wide field FA. Nonperfusion was located initially in the mid-peripheral retina across all levels of DR and progresses posteriorly with increasing DR severity. We also evaluated DR disease worsening and extent of nonperfusion. This figure shows the risk of DR worsening by tertiles of baseline nonperfusion on FA. Eyes with the greatest amount of nonperfusion have the highest risk of DR worsening. This table shows the association of nonperfusion in each retinal zone with DR worsening. Increasing nonperfusion in the posterior pole and mid-periphery were significantly associated with increased DR worsening. Similarly, with increasing overall non-perfusion, there's a significantly increased risk of developing PDR and vitreous hemorrhage. In the protocol AA cohort, after multivariable modeling, increasing non-perfusion on FA was independently associated with an increased risk of DR worsening. The AA data shows us that increasing baseline retinal non-perfusion on ultrawide field FA is associated with increased risk of DR worsening or treatment over time, as well as secondary outcomes such as PDR and vitreous hemorrhage over time. These associations are driven by non-perfusion located primarily in the posterior pole and retinal mid-periphery. We also performed exploratory analysis of this AA data to evaluate the associations of retinal non-perfusion with vision-threatening complications. Vision-threatening complications, as defined here, were used in the analysis. In the AA cohort, 41.1% developed vision-threatening complications over the 4 years of follow-up, with PDR onset in 31%, and center-involved diabetic macular edema in 23.5%. So this figure, shows retinal non-perfusion and its association with vision-threatening complications. As you can see, baseline total non-perfusion was significantly elevated in eyes that developed PDR or concurrent PDR and CIDME within 1 and 2 years. In this cohort, total non-perfusion was not significantly elevated more than 2 years before any outcome. These two figures show the onset of vision-threatening complications and non-perfusion in the posterior pole and retinal mid-periphery. As you can see, elevated baseline total non-perfusion in the posterior pole or mid-periphery were again significantly associated with the onset of PDR within 2 years. This figure shows the onset of PDR and non-perfusion in each retinal zone. We can see the strongest association between baseline non-perfusion and eyes that develop PDR onset within 1 and 2 years. Each 0.1 unit increase in posterior baseline non-perfusion was associated with a 3.7-fold increased risk of PDR onset within 1 year. So in summary, greater baseline retinal non-perfusion was strongly associated with the onset of PDR within the first 2 years. This highlights the potential value of retinal non-perfusion as an early biomarker for identifying eyes at high risk for diabetes-related vision-threatening retinal complications. Retinal non-perfusion commonly begins in the retinal mid-periphery and advances towards the posterior pole as DR severity increases. Progression of retinal non-perfusion into the posterior pole show the strongest associations of PDR onset within 2 years. To conclude, these results suggest that progression of retinal non-perfusion to posterior pole may be an important risk predictor of PDR onset that can identify eyes at risk for rapid disease worsening and development of vision-threatening complications. Furthermore, establishing agreement and clinical consensus among clinicians and researchers on the optimal standardized methods for quantifying retinal non-perfusion and integrating these metrics into current DR severity scales will be important to most accurately identify patients at higher risk for vision-threatening complications and improve patient outcomes. Thank you.
Thank you so much, Dr. Silva. Our next speaker will be Dr. Yali, who is Professor of Ophthalmology and Biomedical and Engineering and the Jennie P. Weeks Professor of Ophthalmology, as well as the Associate Director of the Center for Ophthalmic Optics and Lasers at Oregon Health and Science University. Dr. Jha is one of the world's leading experts on OCTA metrics, and she will speak on AI-driven assessment of nonperfusion on OCTA.
Thank you, Jennie. Hello, I'm Yali from OHSU. I want to thank the invitation from Dr. Jennifer Sohn and the opportunity offered by Mary Taylor Moore Vision Initiative Foundation. That's a great opportunity for me to share my work on AI-driven assessment of nonperfusion using OCTA angiography and its potential as a robust imaging endpoint. Here are my financial disclosures. OCTA angiography is a functional extension of OCT using intrinsic motion contrast to image retinal microvasculature. Since our group introduced split spectrum amplitude decoloration angiography in 2012, OCTA has become a standard clinical tool and received its own CPT code this year. Compared to fluorescein angiography, OCTA provides high-resolution layer-specific images without dye injection. It allows quantitative analysis of deeper capillary plexuses that are affected early in diabetic retinopathy. This illustration compares vessel density and nonperfusion area, two common type method to quantify perfusion status. In a good quality scan, vessels appear continuous and density is high. Poor quality scans break vessels, falsely lowering density value. But nonperfusion area based on intercapillary dropout remains very stable, making it less dependent on scan quality. Our 2023 BGO study confirmed this. Vessel density drops with signal loss, but nonperfusion area remains consistent, especially when measured using AI. Over the years, we have developed the key technology projection resolved OCTA angiography that can help us visualize three distinct retinal layers. Based on this technology, we developed a rule-based method to quantify nonperfusion area by detecting enlarged intercapillary space. Our study shows plexus-specific MPA distinguish the level of DR with greater sensitivity than inner retinal MPA. The MPA on superficial layer is usually more prominent in DR. However, rule-based method is vulnerable to artifacts. AI provides significant advantage here, especially across variable quantity scans, so we can gain access to the data from a lower quality database. Expanding the field of view from 3 to 6 millimeter improves MPA detection. This is very important in diabetic retinopathy, where lesions may extend beyond the central macula. However, the shadow becomes more prevalent on larger scans. Deep learning model allowed us to build context-aware artifacts resilient detection of MPA, especially in the low-quality scans with confounding signal attenuation effect due to shadow or defocus. This method uses multi-channel input, including thickness map and OCT reflectance, to minimize false positives. It can accurately distinguish real nonperfusion area in blue and shadow artifacts in yellow. We carefully validate this approach by placing an iris diaphragm or a filament in front of the eye to simulate signal attenuation artifacts, pupil vignetting, and floater shadows on healthy eyes. We also tuned the autofocus parameters and generated 3 types of defocus scans. Our AI model consistently distinguishes true MPA, here is foveal avascular area, from shadow regions, even under the severe signal loss. This rigorous test gives us high confidence in the model robustness. In real-world clinical images from healthy eyes with shadow artifacts, our AI model correctly labeled MPA and avoided false detection due to shadow. This accuracy is critical for reliable quantification, especially for the multi-site studies. In collaboration with Dr. Jennifer Sohn, we tested MPA detection and quantification methods on DRCR OCTA datasets. Both AI and rule-based methods were tested on a few hundred eyes. This plot shows the severity distribution. It seems that AI method tends to pick up those smaller MPA regions that were identified by the grader. In contrast, the rule-based method failed to identify some MPA in regions with a very strong noise background. As shown in this ROC analysis, AI significantly outperformed a rule-based approach in detecting both referable and vision-threatening DR across most plexuses. This supports AI-based MPA as a strong candidate for a quantitative biomarker. Importantly, MPA is not equivalent to ETDRS severity scores. Here you can see 2 eyes with the same score but different MPA size. Smaller MPA can be demonstrated in a high score. To expand the field view, my team built a prototype wide field system using 500 kHz swab source laser. This enables visualize much larger area, critical for the peripheral MPA analysis and potentially stronger correlation with ETDRS grading system. To summarize, MPA is more stable than vessel density method. AI segmentation improved detection and reduced the artifacts. For the future work, I'm more interested to investigate the wide field and the plexus-specific MPA for predicting DR progress, although we have already shown some promise in our earlier work. I want to thank my dedicated research team and our collaborators at Casey and investigators at DRCR. I am also grateful for the support from a funding agency. Thank you for your attention. I need to hand it back to Dr. Jennifer Sohn. Thank you.
Thank you, Dr. Jha, for that terrific talk. I'd now like to welcome Dr. Elliott Sohn, who is the Endowed Chair of Diabetic Retinopathy Research and Professor of Ophthalmology and Visual Sciences at the University of Iowa. Dr. Sohn is widely known for his translational research expertise in retina, including recent investigations into retinal layer segmentation to understand retinal neural layer thinning as an early predictor of DRD outcomes. He will now give his talk titled Retinal Neurodegeneration, They Precede Microvascular Changes Characteristic of Diabetic Retinopathy in Diabetes Mellitus.
Thank you, Dr. Sohn, for that introduction. It is such an honor to be with all of you today on this webinar. Thank you again to the organizers for the invitation as well to be here with you. I have no relevant financial disclosures to this talk. So the clinical forms of diabetic retinopathy are widely recognized worldwide. We see this as non-proliferative and proliferative forms of diabetic retinopathy and clinically significant macular edema. Now, this has been seen in the retina for decades, since the early 1960s and 1950 here with Kogan and Friedenwald, seeing dilated capillaries, aneurysms, microaneurysms in the retina of patients with diabetes. But more recently, diabetic retinal neurodegeneration, which is what I'm going to be spending my time talking to you about in this session, is becoming increasingly recognized by not just researchers, but now even clinicians around the world. So what is diabetic retinal neurodegeneration, DRN? Well, one way to kind of show you in picture form here is looking at these two donor eyes. On the left is a human with diabetes but no retinopathy, and on the right is an age-matched control. And you can see in red the RPE down at the bottom. The inner retina is at the top of this, where you can see it's labeled in green, labeling the NFL and GCL in these human donor eyes. And what you can see is that in the human with diabetes, you see a thinning of the inner retina compared to the control. Now, when we looked at 6 and 6 of these eyes for a total of 12 eyes, we did see that the NFL GCL was significantly thinner in patients with diabetes and no retinopathy compared to these age-matched controls. So then we also wanted to look at the capillaries. Was there any difference in the microvasculature that we could detect? And there was no difference in capillary density between these two groups. So diabetic retinal neurodegeneration is loss of neuronal structures in the retina associated with diabetes. Now, this can come in several different forms, but we are focusing primarily on the NFL, GCL, IPL layers here, but this has also been seen in the photoreceptor layer as well as some other layers in the retina. So loss of these neuronal structures can occur without evidence of microvascular changes in diabetes. Now, this isn't the first time that this has been described. In the early 1960s, Walton, Ashton suggested that diabetic retinopathy could result from intraretinal degeneration, and Bloodworth also described intraretinal loss from diabetes. And then in an experimental model in 1998, Barber and others published a seminal paper showing apoptosis and ganglion cell loss in diabetic rats, suggesting this diabetic retinal neuroretinal degeneration does exist. But now we have OCT image analysis that can look at these retinal layers and see to just sub-micron level, 0.2 micron, using our automated OCT quantification of these layers with the publicly available Iowa reference algorithms. This is below the resolution that you would see with a clinical OCT unit. As you can see from some of the work that we've done years ago, you can see all these retinal layers are being automatically segmented with this publicly available algorithm. So what we did was we looked at 45 patients in a prospective longitudinal study in type 1 diabetes. With these patients had no to minimal diabetic retinopathy, and we followed them for an average of 70 or median of 73 months of follow-up. And we used our Iowa reference algorithms to automatically quantify the intraretinal layers. So what you can see here is one patient with diabetes and no retinopathy, year 1 on the left, year 4 on the right, where you can see the NFL and the GCL IPL layers really do thin over this 4-year period. So when we calculate these 45 patients and look at the overall loss of these structures, we see a 0.25 micron for NFL and 0.29 micron per year loss in GC IPL over time. This comprises a total of 0.54 micron per year intraretinal loss that happens in patients with diabetes with no to minimal diabetic retinopathy. This is independent of age and glycemic control, but dependent on the duration of diabetes. And when you look at this over years, over decades, what you start to see is intraretinal loss that's similar to rates seen in moderate to severe glaucoma. So then we have to ask ourselves, well, does DRN actually precede vascular changes from diabetes? Is there a way to show this, prove this? Well, I'm going to show you some data just from one animal model. We looked at 2 in our paper here, but just this one animal model of mice in type 1 form using STZ, streptozotocin, to induce diabetes. And we looked at 6 and 20 weeks duration diabetes using OCT. And then we also looked histologically at vessels, capillaries, pericytes, and ganglion cells to compare the differences between these 2 groups of animals. So we used our Iowa reference algorithms for automating this quantification of these intraretinal layers and the other layers in these mice, and this is publicly available as well for mice. What we saw was NFL GCL thinning in the diabetics compared to controls, even at 6 weeks. You can see that on the left here. But at 20 weeks, the difference between the inner retina, between the diabetics and controls, was even more marked. When we looked at ganglion cell density, we didn't see a change at 6 weeks, but we did see this at 20 weeks, where the ganglion cell loss was seen in the diabetics compared to the controls. So looking at the vasculature, we didn't see a difference between the diabetics and controls in acellular capillaries or pericytes at 6 weeks. So to summarize the work done in mice, inner retinal loss is seen on OCT in a more sensitive manner than we saw histologically, but then there was no change in vasculature, retinal pericytes, acellular capillaries, vessel labeling, 20 weeks, did not see any difference between the two groups. So this does really suggest that DRN can be seen with no change in microvasculature, at least in this type 1 model versus controls. And we had a type 2 model that we replicated this as well. So other research groups around the world have seen this, not just in the macula, but also looking at the peripapillary NFL GCL layers, seeing this thinning in humans with diabetes with no to minimal diabetic retinopathy. It's also been demonstrated in animal models. And we've also seen multiple groups showing electrophysiologic detection of inner retinal loss, as well as loss of inner retinal function in eyes with no to minimal diabetic retinopathy. So there are certainly implications that are widespread of DRN. A couple of them listed here. Could this be the earliest manifestation of diabetic eye disease? Could this apply to most, if not all, patients with diabetes? The functional impact of diabetic retinal neuropathy is just starting to be realized, and the role of the neurovascular unit and how DRN plays a role in that is also critical. I know that's going to be a session that Dr. Gardner is going to moderate later in this webinar. More recently, just this year, Carol Chung's group out of Hong Kong did a prospective cohort study looking at 385 eyes with no diabetic retinopathy or NPDR baseline. And what was found was thinner GCL IPL thinning that was significantly associated with a higher risk of not just DR development, but also progression of DR and PDR development. And when you include GC-IPL thickness, this actually helps improve the predictive discrimination for those that will develop diabetic retinopathy. So, in conclusion, diabetes causes an insidious progressive loss of the inner retina that's independent of vasculopathy that can be detected microscopically even, that's independent of glycemic control. And these functional abnormalities, which I didn't get to talk about in depth here, but they can be seen before clinical features of diabetic retinopathy are seen. Early detection of this and diabetic retinal disease might allow prevention of diabetic retinopathy. How? Well, stabilization of the neurovascular unit in diabetes. If we can stop neuronal loss, it's possible because of the tight-knit neurovascular unit. You might also be able to help prevent patients from developing diabetic retinopathy and future vision loss. Thank you very much for your attention, and I'm happy to turn this back to you, Dr. Sohn.
Thank you, Dr. Sohn. We are delighted to have Dr. Stella Vujcevic as our last speaker. She is professor and head of the medical retina unit of the University Eye Clinic at San Giuseppe Hospital in Milano, Italy. She is a leading voice in vascular and degenerative retinal and choroidal diseases with a particular interest in imaging, biochemical, and molecular biomarkers. She will speak on disorganization of retinal inner and outer layers and visual function in diabetic retinopathy.
Thank you, Jennifer, for the kind introduction. I'm Stella Vujcevic from the University of Milan, and my presentation will be on disorganization of retinal inner and outer layers and visual function in diabetic retinopathy. These are my financial disclosures, none relevant to this presentation. So patients with diabetes mellitus have microvascular, neurodegenerative, and neuroinflammatory modifications in the retina that ultimately lead to the clinical signs of diabetic retinopathy. We know that the neurovascular unit is composed of different cells within the retina, and they have different roles, and they are crucial in the integrity of the inner blood-retinal barrier. The neurovascular unit is composed by retinal vasculature, by retinal glial cells, both the macroglial and microglial cells, and also by the retinal neurons. The neurovascular unit is crucial in maintaining the integrity, as I said, of the inner blood-retinal barrier. The microglial cells, amacrine cells, and endothelial cells form the neurovascular unit, and they are part of the inner blood-retinal barrier, which transports 2/3 of the substances across retinal capillaries to extracellular tissue, and 2/3 compared to the 1/3 that is performed by the outer blood-retinal barrier. So the overtime diabetes damages the neurovascular unit, affecting both the anatomical and physiological processes. And that's why we have also at the very early stages of the disease, the functional impairment in the retina. So the visual loss actually, the visual loss that is evaluated by best corrected visual acuity is detected only, let's say, at the late stage of the disease after many years of the disease. But at the early stages of the disease, there is this concept of functional diabetic retinopathy that is due to diabetic retinal neurodegenerations and which precedes the vasculopathy and also the clinical signs of diabetic retinopathy. So actually the functional impairment, which can be detected by some other tests, for example, ERGs or contrast sensitivity, color vision, perimetry, and so on, seems to be much more precocious than actually the decrease in the best corrected visual acuity, which is a high contrast text. So in the context of the neurodegeneration of the retina, there is the concept of the drill, so disorganization of the inner retinal layers, which is the sign on OCT, the absence of detectable boundaries between the ganglion cell inner plexiform layer, complex inner nuclear layer, and outer plexiform layer, firstly described by Jennie most than 10 years ago. Drill may indicate disorganization of the cells within the inner retinal layers with a dysfunction in the normal cellular activity between the photoreceptors and the ganglion cells. It is associated with the worse visual acuity and also with the severity of diabetic retinopathy. Firstly, it was described and noticed in diabetic macular edema, but then later it has also been described in the resolved diabetic macular edema, as you can see here on the image on your right side. Not just the disorganization of the inner retinal layers, but also the outer retinal layers, especially the EZ of the photoreceptors, can be damaged. And then in this case, it has been called the DROL, so disorganization of the outer retinal layers. A recent paper showed that in diabetics type 1, the early intensive glycemic management and controls lowers the risk of development of drill and macular edema. A change in drill extension was proposed as a prognostic biomarker in diabetic macular edema and also center-involved DME, and also as a predictive biomarker of visual acuity in response to the treatment in DME. And some groups have shown that, for example, when treating DME with anti-VEGF drugs, the presence at baseline, for example, of drills and some other signs such as hyperreflective spots of foci, disruption of the outer retinal layers, are all associated with the worst prognosis after anti-VEGF treatment. And other groups have shown that actually the patients with DME and drill, if they are treated with the intravitreal steroids, there seems to be a decrease in the extension of the drill when evaluated on OCT. Drill has also been associated with the presence of the ischemia in the macula and neuronal changes, and also with the changes of the ellipsoid zone of the photoreceptors. And the ischemia that has been described also is the multi-level ischemia, so involving both the superficial but especially the deeper capillary plexus. And also, for example, in patients with macular ischemia that have stable PDR and have the drill, and E zeta loss, it was shown that the visual acuity is much lower than in patients without these characteristics. In a recent paper that published by our group, we evaluated several grades of severity of the disorganization of retinal layers. So inner retinal layers DRIL, then outer retinal layers DROL, and then also when E zeta is involved, we called it DROL plus. And we found that in these cases, there was a much higher functional impairment, both when evaluated best corrected visual acuity and also retinal sensitivity that was evaluated with the microperimetry. And also there was major changes in the microvascular parameters evaluated with the OCTA. So the perfusion and vessel density of the ICP and DCP were significantly decreased in cases with the disorganization of retinal layers, as well as there was a major choriocapillaris flow voids. These were increased with the major severity of the disorganization of retinal layers. A recent prospective study that evaluated the incidence of visual loss in patients with DMI showed that when you have the presence of DRIL, these cases will probably develop a visual functional loss compared to the cases without the presence of the DRIL at baseline. Now, with the novel OCT machines such as the high resolution OCT, there is the possibility to evaluate even better these drills. And also it was shown that DRIL progresses in the vertical way. So from the inner retinal layers to the outer retinal layers, much more than in the extension or horizontal layer. And the AI recently was applied also to evaluate the drills and to measure it. And the identification of drills at baseline may be useful in clinical trials for stratifying, for example, patients based on their prognosis. So to conclude, DRIL may indicate disorganization of the cells within inner retinal layers, and also it is associated with major functional impairment in these patients. Microperimetry and visual acuity can detect the visual impairment in these cases, and it seems that the disorganization of retinal layers that involve outer retinal layers and E zeta loss are those correlated to major functional impairment and also to the ischemia at the deeper retinal layers. With this, I have finished, and I pass on you, Jennifer, for the rest of the meeting. Thank you.
Thank you so much, Dr. Vujicevic, for that fascinating presentation.